Tokyolive
Endoscopy
Endoscopic 1.
Hello, everyone. I'm really honored to chair this session and co-chairing with Professor Haruhiro Inoue, who is the director of this Tokyolive 2021 course. And I'm Professor Philip Chiu from the Faculty of Medicine, Chinese University of Hong Kong. And today we are joined with two renowned speakers internationally, Dr. Noria Uedo and Dr. Stavros Safopoulos. Without further ado, we start this session on endoscopic full thickness resection of the upper GI, which is now currently one of the hottest topic in endoscopy and also the frontier in development of endoscopic resections. The first speaker is Dr. Noria Uedo, and Noria is a longtime good friend of mine, and he is currently serving as Vice Director of Department of Gastrointestinal Oncology, Osaka International Cancer Institute. And Noria actually graduated from School of Medicine, Kikushima University in 1992, and he has a lot of visiting professorship and physicianship from all around the world, including Case Western Reserve University, Lund University in Sweden, PLA General Hospital in China, and also a lot like the Changi General Hospital in Singapore. And he's also counselor of a lot of associations, including the Japanese Gastroenterological Endoscopy Society, and also associate editor to Annals of Gastroenterology and also Endoscopy International Open. So Noria, we are excited to hear your talk about endoscopic full thickness resection.
Thank you, Philip. Kind introduction. So actually, I prepare a video recording presentation because I think it's better because of my English speak or something. Thank you, Professor Inoue and organizers for giving me opportunity to be involved in this outstanding live course. I am talking about experience of implementation of EFTR in a practice. GIST is a mesenchymal tumor that originates from Cahal's interstitial cells by gaining functional mutation of c-KIT gene. As the GIST is regarded as potentially malignant, having tendency of growing and risk of metastasis, it is considered to be indication of resection treatment. So recent guideline recommends surgical resection for histologically proven or clinically suspicious GIST in clinical practice. However, although most treatment for GIST are prophylactic purpose, excessive gastric partial resection is needed for lesion at the cardia or pylorus, where laparoscopic local resection is difficult. But GIST are theoretically suitable for local excision because it does not require lymph node dissection or much resection of the margin during surgery. Recently, there are many reports of endoscopic full thickness resection (EFTR) for gastric mesenchymal tumor overseas, especially from China. So what is the benefit of EFTR for gastric SMT? When we perform laparoscopic resection for gastric SMT, especially intraluminal growth type, we have to remove large area of gastric wall. In laparoscopic and endoscopic cooperative surgery, we can reduce the gastric wall defect, but in case of lesion located on the lesser curvature of somewhere, to close the wall defect, we need to dissect extraluminal tissue such as lesser omentum, which includes vessel or vagal nerve inside. In contrast, EFTR can minimize gastric wall defect and damage of extraluminal tissue and may contribute preservation of organ function after the treatment. As I mentioned, this procedure is prevalent in China. But our question was whether this procedure can be implemented into Japanese clinical practice or not. To answer this question, initially we have to manage issues regarding ethical approval and social insurance coverage, because all Japanese clinical practice is conducted based on social insurance payment. In 2017, we submitted the first study protocol to our IRB. And during some interview, Dr. Stavros' lecture given in China was really helpful, and I want to thank again in this opportunity. But anyway, we have got approval from IRB, and eventually social insurance coverage as an advanced medical care. Therefore, we can perform EFTR for gastric SMT size between 11 to 30 mm originated from the muscularis propria from September 2020. So EFTR became clinically feasible in our practice. I visited Shanghai to observe real procedures of EFTR and studied the procedure in our hospital. During our experience of EFTR procedures, we noticed that there are some similarities and differences between ESD and EFTR procedures. So, I summarize these points in this presentation. The similarity includes basic usage of end knives and the electrosurgical unit, and importance of deep mucosal incision, efficacy of traction device, importance of vessel recognition and coagulation during tissue dissection, and a paracentesis for pneumoperitoneum. For both ESD and EFTR, the same knives and electrosurgical unit can be used, and water jet scope with cap is useful. And in ESD, deep mucosal incision, we call it as trimming, is important because it makes the last and lateral tissue dissection easier. For example, after mucosal incision, we make it deep until the surface of muscularis propria. So, the completion of lateral dissection or distal dissection becomes easy. Similarly, with trimming, we can identify muscle attachment well and easily complete muscle incision during EFTR. Traction device is useful for both ESD and EFTR to clarify the dissection plane, making the tissue dissection efficient and safe. Vessel recognition and coagulation during tissue dissection is important, both ESD and EFTR. Especially, I thought IT knife is useful for safe tissue dissection, because during the dissection of the tissue, insulated tip protect thermal damage of the distal tissue to the knife. Maybe you can see the distal vessel is remaining because of insulation of electrode cautery by the ceramic tip. Especially it is important for EFTR because we can avoid injury of capsule by the ceramic tip. And we can avoid injury of vessels in the distal tissue. And in case of pneumoperitoneum, we use paracentesis for abdominal decompression. Difference of procedure includes requirement of general anesthesia, start of mucosal incision from inside the tumor margin, dissection near tumor surface, and requirement of strong closure method for perforation in EFTR. In ESD, we have to start incision from a bit outside of the tumor margin. But if we do it in EFTR, the mucosal defect becomes very large and defect closure becomes difficult. So in EFTR, it is better to start mucosal incision a bit inside the margin of the tumor. In ESD, we usually dissect some mucosal tissue near the muscularis propria. But in EFTR, we usually dissect the tissue near tumor surface. Because in ESD, we want to recognize the muscularis propria and avoid perforation. But in EFTR, we want to recognize tumor surface and avoid damage of the capsule. In ESD, perforation is easily closed with simple clipping because the ESD perforation is linear incision. However, closure of perforation in EFTR requires stronger closure method than that of ESD. We usually use purse string suture method because we don't have endo stitch in Japan. But OTSC suturing device such as overstitch or zero suture M are also available, and development of effective suturing method is awaited. I show one case of extraluminal type cyst. Basically, this is useful for laparoscopic resection, but I want to show this as an example. So, initial mucosal incision is start from a little bit inside of the tumor margin. Then, we make the incision line deeper to expose all muscle attachment of the tumor. And then, we make muscle incision to the tumor, recognizing the tumor surface like this. And after that, we attach the clip and thread to the surface of the tumor and then make traction in order to see surrounding tissue plane very well. And then keep tissue dissection the tumor. If we expose whole muscle attachment, edge of muscle attachment easily identify and complete the lateral and the last muscle incision. After the removal of the tumor, we put endo clip and attach the endo loop and then close the muscle defect completely. In summary, EFTR for small cyst is feasible in selected cases. And we are just opening a window of EFTR procedure for Japanese endoscopy practice. Many ESD techniques can be adapted to EFTR procedures, and understanding of similarity and difference of procedures facilitate its implementation. Thank you for kind attention.
Thank you very much, Noria, for your wonderful lecture. And it demonstrates the actually adoption of ESD technique to the performance of EFTR. And I'm amazed by actually the video that showed such a big extraluminal GIST tumor that you can resect by endoscopy. So I have a few questions to you regarding this. And firstly is that, for example, like in this kind of a very big extraluminal component lesion, would you also consider having some surgical and endoscopic combination procedure like laparoscopic, endoscopic collaborative surgery?
So we always discuss with surgeon about it, but our surgeon, if it is possible to remove by endoscopy, you can do it. They said you can do it because it's not necessary to, make a port and then, extraluminal, dissection, tissue dissection, something. So if it can be removed from intraluminal side, they say that it's minimally invasive. So our surgeon is very helpful.
Yeah, I also fully agree with you, actually, and also your surgeon, that if you can do it, then the pain is much less, trauma is much less. Yeah. And while I can also see the principle is very important of keeping the integrity of the capsule of the tumor to avoid tumor seeding. And that is one of the important factors towards recurrence of the GIST. So how do you select cases? For example, what are your investigations that you should do before you decide on whether you do EFTR or laparoscopic collaborative surgery?
So basically, we still limited the indication to from size from 11 to 30. It means we have to measure the size actually with image examination, such as EUS and CT scan. So that is, we always perform at least two examination to measure. And we found that EUS is very good to assess which is more intraluminal or extraluminal or relation between gastric wall. And also, but sometimes only EUS size measurement is only one, section. So sometimes CT scan, 3D CT scan is easy to assess the shape and the size according to comparison with other organs. So I think the examination is very important to make an indication, to decide the indication.
Yeah, I think similar to your comment, actually, I do the same. And also I found that only one imaging like EUS is difficult because it's only one plane. And the dimension is almost always different when you are resecting that lesion because it's a 3D and EUS is only 2D. So yes. CT is very helpful. And extraluminal component, as you mentioned, is also important to decide which treatment should be the best or to be prepared for any kind of mostly extraluminal management. So for example, like in your case, if the most component is outside, then there could be a lot of gas leakage. So besides the paracentesis of the gas, any other important tips and tricks you would do to avoid too much of the gaseous dissension?
And also, we are endoscopists, so I always discuss with surgeon because they know local anatomy very well. So your surgeon, it's not necessary, but for us, help or assistance of surgeon is very important, I think.
Yes, agree with you. So any comment or question from Haru, Professor Inoue, or Stavros?
Yes, can I? So that's a short question. So Uedo Sensei, thank you so much. Wonderful lecture. I have a very short question. So, like your demonstration, when we open the stomach, sometimes even when we tap the abdominal wall, sometimes we lose the endoscopic view in the stomach. So, is there any special tricks to keep the good endoscopic vision during full thickness resection?
So I asked the same question to our Chinese friends. So he also said that if we really inflate the areas continuously, so we still have some space in the stomach. So if the defect is very large, probably it's very difficult. But if the effect is still limited, so if we insufflate the air as much as continuously, so we still have some space for the procedure. And after the one closure, it becomes more better. So that is maybe, tips. Or maybe we can ask Stavros how to, because he removed very large one. So is there any answer for the, in case of gastric wall defect, how to?
I agree with my Chinese friends. You keep insufflating, and then I use the needle I use for decompression is small. I think it's something like, I don't know, 20 gauge. So I think the escape of gas is at a low rate. It's just enough not to get very high peak airway pressures, but not so much that you lose insufflation. So I think if you use a small needle, I think it's okay.
Okay, thank you. So, Philip, can I move on to the
yes, please. Yes, please.
Yes, it's my honor and pleasure to introduce Dr. Stavros Stavropoulos. He has no need to introduction, but he's the director of the therapeutic endoscopy program of the Winthrop University Hospital, New York. He's really a king of EFTR, and yes, he's a brave, one of the best innovative endoscopists in the world. So he also organized the Long Island Live. It's one I like most, his course. It's so, yes, he challenges many innovative therapeutic endoscopies. So welcome, Dr. Stavros.
Thank you. Let me try to share the screen. Yes?
Yes.
Okay, thank you very much. So Haru, thank you for the introduction, and absolutely it's an amazing privilege to be invited to lecture at Tokyolive. It's an amazing course, and I'm really honored. And it's good to see Philip also and Nori after a year maybe or more since we last met. So it's a great honor. Most of my lectures on EFTR focused in the past on techniques. This talk is more based on data and outcomes and follow-up algorithms, because I think it's very important to also, once we are able to do something, to think about why we're doing it. I hear a lot of criticism from surgeons about the indications, what tumors we pick to do it on, and also some criticisms about whether we may have an incomplete resection with endoscopy as opposed to surgery. So I think it's good to look at our data periodically and see how good a job we are doing. So I'm going to focus on the nodes techniques, EFTR instead. There's a whole slew of minimally invasive endoscopic resections for subepithelial tumors, starting with the most primitive ones, the excavation ones, ESD, EMD, ESC. They are only suitable for small intraluminal tumors with limited MP attachment, and incomplete removal is likely. There's the device-assisted ones, more recently the vascular device, the FTRD, and also the Gerdex techniques. They are again only suitable for small intraluminal tumors. The collaborative techniques, such as LEX, are cumbersome with complex logistics coordinating endoscopy and surgery, and the invasiveness is similar to surgery, so why not just do it surgically once you get to this level? And finally, the ones that we'll talk about are obviously the nodes techniques. They have wide applicability all the way up to 5-centimeter tumors, intraluminal or extraluminal, but they require pretty advanced skills in ESD and nodes. So that's where I'm going to focus. And these are the techniques in pictures. The tunnel technique, first reported by Haru, among others, in 2012, an offshoot of POEM, and then the EFTR, first reported from Chinese groups, full thickness direct excision, and then closure with clips. In this case, we use overstitch. So, in some cases from our series to illustrate, this is a stir of the EGJ tumor in the G junction, usually leiomyoma. The EUS shows the classic appearance, hypoechoic, involving marginally the muscle. And then we have to do a tunnel. It's not visible from the esophagus, so usually it's useful to put like some cautery marks to guide in which orientation you should make the tunnel so you don't miss the tumor. And then the rest is similar to POEM, injection, entry into the submucosal plane, dissection, first on the mucosal side of the tumor, and that's exposed now, and then on the muscle side of the tumor until it's completely removed. And, nice defect left in the submucosa where the tumor used to be. This, you can see a fold in the mucosa in the fundus. We've got to be careful not to devitalize this mucosa and make it ischemic, because then you can get a delayed perforation. And that's the full thickness defect. You can see serosa and the fascia covering the left crush, or I guess the left part of the right crush of the diaphragm. There, and full thickness resection, and on retroflexion the tumor is gone. There's some edema there, and there's a tumor about 4.5 centimeters by 3, and it was a leiomyoma, low risk, very nicely removed. We had to enlarge the opening to remove it, which happens sometimes, and therefore suturing here would have ended up closing the lumen down, so we had to use clips. We usually use suturing. And then for EFTR, this is a large prepyloric gist with high vascularity, big tumor on the anterior wall, lesser curvature of the antrum just before the pylorus. The patient would have required a Billroth 2 normally, but we were able to do EFTR. The surgeons are actually grateful that we do that, and they're even happy if they need to close the hole for us, as opposed to having to do a Billroth 2. So very high vascularity. You can see the tumor starts in the wall, very near the mesenteric gastroduodenal branches, near the pylorus, and then you can see it goes extraluminally near the mesenteric branches. And this is what the resection looked like. Muscle, as Noria showed, you start very close to the tumor edge. You have muscle exposed, mucosa, and this is the capsule of the tumor. The muscle is wrapping onto the capsule. We delay doing a full thickness entry as late as possible, exactly not to lose insufflation, not to risk contamination. So after we marginate completely the tumor, that's when we enter full thickness and then start cutting the muscularis, respecting the capsule of the tumor. And you have vessels from the mesentery feeding the tumor. We use coag graspers there very carefully. And finally, you see the end result, a lot of capnoperitoneum in the abdomen. We put the scope through and evacuate the capnoperitoneum, check that we don't have any injuries to any wall of the stomach or any other adjacent organs. And then we close with the overstitch, very effective. Even on the anterior wall, actually, it can be done very well. And there is the complete closure. And then there's that 5 centimeter tumor. It has its mucosa attached. The pathologist wants that. It helps orient them to the luminal pole versus the peritoneal pole. And about 5 centimeter gist, which had only a hematotic rate of 4 and no recurrence at 4 years of follow-up. So now let's look at the data. So what tumor should we do it on? And I saw the Japanese guidelines reviewed by Noria, which are very similar to what Abe published in Digestive Endoscopy in 2008. Basically, anything bigger than 3 centimeters goes to LEX if intraluminal, or wedge resection if extraluminal, or if it's ulcerated. All intraluminal tumors on the anterior posterior wall, where it's difficult to close because you lose the air very readily, as opposed to lesser greater curvature, LEX. And EFTR is only really restricted for intraluminal tumors less than 30 millimeters on the lesser or greater curvature. our approach is this is a nice conservative approach. Ours is more liberal in the US. We look at tumors all the way up to 50 millimeters for EFTR, whether intraluminal or extraluminal, we don't care. And ulceration, I don't think is as important in the mucosal side. And our approach may arise from our basically greater ability to close the defects with overstitch. Maybe that's why we're a little more aggressive. And then the problem is removing the tumor from the mouth. Once the short diameter is more than 30 millimeters, that can be tricky. But our surgeons are very happy, if needed, to come and do a simple laparoscopic extraction after we close our own hole and the tumor is rolling around the stomach. Even a few hours later, we can send the patient up to the OR for extraction of the tumor. So what do we do for indications for each category of tumors? For GIST, it's NCCN guidelines, basically, plus patient preference. The NCCN guidelines do not say to remove tumors less than 2 centimeters, but you have a young patient that doesn't want to have anxiety and surveillance forever, you can basically discuss cost-benefit and remove them. These are very easy to remove also, less than 2 centimeters. Non-GIST mesenchymal tumors, leiomyomas, schwannomas, granular cell, glomus, etc. Similar guidelines, if they're symptomatic or large, we remove them. And again, for young patients to prevent surveillance, especially if you can't get a diagnosis, very reasonable. Neuroendocrine tumors, the T1s clearly are amenable to ESD. So when do you use EFTR? Well, for the things that NCCA guidelines says need a wedge resection, but not a lymphadenectomy, these are appropriate for EFTR. Then if you can't get a diagnosis, the indeterminate says you can do the EFTR and finally get a diagnosis and eliminate surveillance. And finally, for epithelial neoplasms, things that are very fibrotic, but also things where you might not disseminate neoplastic cells, because this is not a closed EFTR, it's an open EFTR. Those two conditions are met, then you can do a full thickness resection. So this is what we did over 8 years. These are our current iteration of our series, 164 cases. You can see 1/3 is very advanced comorbidity. That's why they are not good candidates for surgery. Then most in the stomach, most EFTR, 75%, resection time, mean size, most closed with suturing, 98% on block. We aborted 3 for various reasons and electively did surgery, non-emergently. And then 15, we had the surgeon do a laparoscopic retrieval because they were too big to remove from the mouth. And you can see 125 subepithelial tumors, 16 were epithelial neoplasms that were fibrotic and stuck into the wall. And then 23 were benign, but we didn't know that on the basis of the prior CURSCT. So this was diagnostic EFTR. Length of stay, reasonable. Only length of stay more than 7 days, only 9. Only 1 stayed up to more than 7 days. It was our only severe complication, an infected pleural effusion after a stir that required a drain and a stent, and the patient was observed on antibiotics. Everything else pretty manageable, small bleeds and some minor adverse events, and no deaths or long-term disability or sequela. So, pretty reasonable results and probably better than surgical results. So how do you follow up these patients? We follow NCCN guidelines for GIST and NETs, and for the rest of them, the low-risk leiomyomas and the like, we follow mainly the large ones, or the ones that are not R0. So basically 83% were eligible for follow-up, 11 haven't reached the follow-up point at 1 year, and 31, no follow-up was needed, mainly low-risk GI mesenchymal tumors less than 2 centimeters and R0. And the rest, no, 3 had surgery, 2 died from other causes, 1 was too elderly to bother. So you can see 89% had an endoscopic follow-up with 0% recurrence at 24 months, 65% had imaging with CT, again, no recurrence. Only 8 were high risk, and we send them to oncology or surgery. So 6%, 5 GISTs, 2 NETs, and 1 leiomyoma with sarcoma features. You can see here the GISTs, 42% very low risk, 39% low risk, 16% intermediate risk, and only 3%, two of them were high risk. I'll show you what we did with those. Follow-up of GISTs. Very low risk got endoscopy, low risk intermediate and high risk endoscopy and CAT scan. And you can see that at 27 months for CT and 33 months of EUS, no recurrence. The 5 that had mitotic rate more than 5, 7% of all GISTs, all gastric, that were referred to oncology. Only 1 got imatinib. The other 2, the oncologists declined because they felt that the risk wasn't high enough. 1 patient died from other causes before getting imatinib, and 1 patient refused. None of them has any recurrences. Now, the neuroendocrine tumors are trickier. There were 6 of them. We had 2 type 1 carcinoids with R0 resections, very good, no recurrence, doing very well. Rectum, we had 1 T1, no follow-up needed. We had 1 T1 with lymphatic invasion. We sent to surgery. Now she's 40 months out with no negative, and the surgery was negative, the specimen. Another one was T2 due to size, and is doing well on follow-up. In the duodenum, when we attempted to resect this one, we discovered during the EFTR that it was a T3 going into the subserosa. For a duodenal tumor of this size in the subserosa, clearly lymphadenectomy is required. So we stopped, we sutured him up, and then a few months later he got a Whipple, which did confirm a T3 tumor. And he has no recurrence now 12 months after that surgery. For the low-risk mesenchymal tumors, mostly leiomyomas, the 24 that were eligible for follow-up, no recurrence. 1 had a leiomyoma with sarcomatous features. She got a prophylactic left colectomy with negative pathology. She's disease-free at 8 years. Now, in terms of R0 resection, and that's tricky for these situations, and I'll discuss this more. If you exclude the 23 benign lesions, that leaves 16 epithelial neoplasms, R0 94%, and 125 subepithelial tumors, 2 aborted, but the R0 on the rest was 86%. All the R1 resections, but 1, which was piecemeal, were actually on block. But because we did not give any normal tissue to the pathologist beyond the tumor, he or she could not feel she could call it an R0. But it was a complete endoscopic resection. So this is the tricky part about this. So how is the long-term results at 2 years from other series? There are 7 series that reported EFTR stay outcomes at more than 2 years. The percent of high-risk GISTs were generally low, and the mean tumor size was 1.5 to 2.3. Unfortunately, most of these studies reported outcomes on a very small proportion of EFTRs and stairs, mixed in with many excavation type procedures, ESD, EMD, SEMR. So it's a mixed data here. 2 studies were only on stair, 1 study stair versus EFTR, but the 6 other studies were a few EFTRs mixed in with the ESDs, EMDs, and ESCs. The 2 largest ones only had 14% and 21% EFTRs. The rest was excavations. On block, more than 90%. Our R0 rates vary a lot, depending on what resection you use. 26% in this study, where 88% of the resections were ESD and EMR excavations. 43% in this study, where 77% were ESCs. In the 80s on other studies, and as high as 100% in the study by ABE, where 58% of the resections were ESD, EMD. So what about recurrences on long-term follow-up? 2 out of 90 in this study, 1 R1 ESD of a 3 centimeter cardiac GIST, 1 R1 stair of 2 centimeter gastric body GIST, both local recurrences detected on biopsy during EGD. On the surgical group on this study, there were 2 real recurrences with metastases into huge GISTs that were removed surgically. In this study, again, there were distant metastases, but only in the surgical group at 19 and 27 months. In this group, there were 2 local recurrences from endoscopy. Again, R1 ESC on a 1.2 centimeter distant of fundus, R0 stair of a leiomyoma. They concluded that R1 resection doesn't make any difference in terms of recurrence, and it's okay. So in conclusion, any few recurrences here were due to incomplete resection. 2 were due to excavation procedures, and 2 were due to stair. None of the recurrences were from an EFTR. An R1 resection does not really predict recurrence if the endoscopist is certain that they did a nice endoscopic R0. So in conclusion, EFTR and stair offer minimally invasive removal, definitive diagnosis, and risk stratification of sets 5 centimeters or less. eliminating uncertainty, invasive surgery, and lifelong surveillance. High complete on-block resection with favorable safety and negligible recurrence is seen at long-term follow-up, and a low percentage of patients are referred to oncology or surgery due to high-risk features with negligible recurrence and no metastatic disease reported so far. Thank you.
So thank you very much, Dr. Stavropoulos. Great lecture, and congratulations with the great results. And I have several brief questions. So I think when I visit your hospital, and then I watched your live demonstrations, so maybe I think the overstitch, that is from Apollo, it's a game changer of the full thickness resection. So do you have do you think you have a chance to close a small defect using clips, or all the case should be closed by the overstitch?
Well, as you know, Long Island, New York is, a very high litigation area with a lot of lawyers. So I sleep a lot easier by spending a little extra time to stitch things up. But there are some locations where overstitch is very difficult. Very deep in the fundus is difficult. The anterior wall proximally is difficult. And the medial wall of the duodenum, or the anterior medial wall of the duodenum, is very difficult. So there you may have occasionally to depend on clips. But now Apollo came up with this new system, the X-Tack system, which has little screws that are connected with a suture. The end result is very similar with putting an endo loop around clips, because the suture passes through a little ring at the stem of these little screws that you just screw in the tissue. And then you just purse string the suture using the same cinch that the overstitch uses. So the end result looks exactly like a bunch of purse string clips that were brought together with an endo loop. Now, I wouldn't use this for a big defect, because you have metal to metal instead of the tissue to tissue approximation that the suture can do. Chris Gostout said when they did in animals the X-Tack for full thickness, I think 1 out of the 5 pigs developed a leak and peritonitis. So I think for small defects, especially if overstitch is impossible, something like the X-Tack or endo loop with clips may be appropriate, with very close follow-up, NG tube suction. Normally I don't do NG tube anymore if I do overstitch, but there I would use NG tube aspiration and other protective measures.
Okay, thank you very much. It's a very important point. And you also mentioned you mentioned that the location of the tumor sometimes easy to do, and the difficult part of the stomach to do the EFTR. Would you comment on it?
In the stomach.
In the stomach, difficult part.
Yes, the proximal anterior wall is a problem, and the proximal greater curvature, and the anterior wall is a problem, because the endoscope has trouble reaching, and the very deep fundus towards the medial part of the fundus, like really next to the esophagus in the fundus. That's difficult for us in the United States. Because, I get very little retroflexion from my Olympus scopes. I don't have a double bending scope. So, these are very difficult. We come up with all kinds of tricks. I published in Video GIE a case of a fundus gist with 3 different tricks, using a pulley to pull the defect down so I can suture it. And, using a 360 loop on the endoscope, like retroflexing and pushing the scope all the way up into the fundus until it gets there tangentially. These are, complicated maneuvers, but you have double bending scope, or I tell you, another company has much better retroflexing scopes in the United States. So a lot of us use that. But retroflexion is critical, both for the anterior wall, but also the deep fundus.
So, yes, thank you very much. Stavros, it's a great lecture. And we have a discussion all together. So, Philip, you have any question to two speakers?
Yeah, thank you, Haru. And I think Stavros is a really wonderful, outcome, and you demonstrate 164 cases and demonstrating different techniques of resection. So I guess from your lecture, I can see that for gastric GIST tumor or NET tumor, it's probably best to be managed by EFTR. With a en-bloc resection, and you can also demonstrate in the literature, the recurrence rate is really, really low with the EFTR as compared to other techniques. So how about some mucosal tumor in the other sites, for example, like the esophagus? So which is your preferred approach, EFTR or STIR or POET?
The esophagus STIR or POET. Because, it's very difficult to close a big defect in the esophagus. You lost it without eliminating the lumen of the esophagus. The few times when I ended up with the necessary EFTR kind of defect, I utilized, for example, stents, because this is so difficult to close a large defect, especially towards the AG junction. Where things narrow, it's very difficult to not eliminate the lumen. So yeah, I don't like STIR as much as EFTR, and my only severe complication was on a STIR. If you asked me before I started doing this 8 years ago, what would scare me the most about the severe complication, obviously it would be EFTR, but STIR scares me more because it's the chest, and because this tunnel, when you pull a big tumor through, can be a very devitalized, ischemic piece of mucosa, all tattered. And, once this falls apart, you have nothing, no protection.
Yeah, fully agree with you. But the difficulty lies in the esophagus full thickness closure. I also agree. It's very difficult sometimes. And also one more question, maybe just a comment about the latest system. I can see you are still using the double channel overstitch. There is a single channel version. So how do you compare, or do you like to use the single or the double channel overstitch?
That falls on you can't teach an old dog new tricks kind of thing, I think. Chris Gostout was very supportive of this system because a lot of parts of the world don't have that many double channel scopes, apparently China. And also a lot of private practices in the United States that try to do the endoscopic sleeve gastroplasties don't want to invest in double channel scopes. So from a marketing perspective, it makes sense. But I did 3 cases and I just threw it out and I don't want to see it again. I just, the way you set it up and taping it and the way the geometry of the tip, maybe it's because I've done 1,000 cases of overstitch and it's very difficult now to change my mind to something new, or objectively, it's just not as good as the double channel one. I think the double channel offers advantages, but I want to be fair. I've only done 3 with the other one. And I'm just not willing to put the effort to do more, to do a good comparison. So I don't want to besmirch it with so little data, but I'm a believer in the double channel one.
Yeah, I also agree with you. I have not 1,000 suturing, but hundreds one. And frankly speaking, the single channel, sometimes the orientation is not directly with the scope. So you need to change the scope to allocate the suturing device.
Right.
And it's a kind of coaxial rather than in the same axis. So sometimes a little bit tricky. Yes, I agree with you. Thank you, Stavros.
Thank you.
Haru, back to you.
Yeah, thank you very much. So at the very end of this session, I'd like to ask you
Can I ask a question? For indication, you mentioned that the size 5 centimeter, but usually 5 centimeter is impossible to retrieve from the mouth. So you mentioned that the short axis is 3 centimeter, within 3 centimeter. Is it right?
Well, yeah, if you have a little woman that is 4 feet high, even the 3 centimeters may not work. So it depends on the size of the patient's esophagus. But about 3.5, maybe I've been able to remove with careful wiggling. But it's a tricky situation because there's a report, for example, in Video GIE, I think, of somebody dying because somebody removed a hamartoma from the duodenum that was 3.5, and they were trying to remove it from her esophagus and caused a tear, and they could just not close it. I mean, it's a terrible. You can imagine, you tear the esophagus, and now you have a tumor stuck in the middle of the esophagus with a tear, and you call the surgeon. They probably want to kill you, as opposed to calling them to do a little gastrotomy in the antrum, and in a nanosecond, remove the tumor through an umbilical port with, and my surgeon does it with 2 mini lap ports with just needlescopic instruments and just 1 big port in the umbilicus. Like that's 1,000 times easier. So I don't push it because I'm always afraid I'll get with a tumor stuck in the esophagus and a tear, which is a disaster to fix compared to just leaving the tumor in the stomach. So, I mean, once you see that it's not coming, you have to carefully push it back into the stomach. And then, my surgeons can do it in like 25, 30 minutes. They can do a new hole wherever it's easy for them. And I hand the specimen into their specimen bag, and they pull it out the umbilicus, wiggling. And then they just stitch they use endostitch or just, freehand suturing, and they close the hole, just in the antrum, where they don't even have to dissect any mesentery in the exposed area of the anterior antrum. So I don't think we should sweat it too much and cause any injury in the esophagus or get the tumor stuck there.
Okay. And sorry, short last question, but you mentioned probably interpretation or evaluation of RZ resection is very important and controversial issue. So basically, mesenchymal tumor, it is very difficult to define R0 resection in histology. And sometimes even the procedure we try to avoid, but sometimes scope scratch the surface and cause some, capsule tear or something. So what do you think about, or how do you manage the, R1 or capsule damage?
Well, then you're not going to avoid the R1. I have my pathologist look at the macroscopic specimen and that is how that helps them say if it's R0 or not.
Yeah.
Because I went and looked at under the microscope with them, and there's no identifiable capsule microscopically. So, but macroscopically, interestingly, you can see that that the capsule is there when it has been breathed.
Yes.
So I have them carefully photograph the specimen and look at the peritoneal side surface, and then they come up with R0 or R1. Now I know if it's really an R0, and I just burned the capsule because some vessel started bleeding, and I had to burn it, and now the capsule looks damaged there, as opposed to leaving a piece, which I really never do these days. So I think there is a concept. I don't like calling it endoscopic R0, like some people do, because R0 is R0 and it's histology. But you can call it endoscopic complete resection, where the endoscopist is confident that they didn't complete. So then I tell the patient and the oncologist, look, it's R1, but it's an endoscopic complete resection. I basically guarantee it, because then you have to decide, do I give imatinib, do I not give imatinib? So I go also on the record on what my opinion is on whether I may have left. But for EFTR, it's impossible really to leave a piece.
Yeah.
Probably the problem.
Yeah,
The
yeah.
stair, especially myomas, can fracture. They have little extensions like tentacles going into many places. Like the myomas can be extremely regular. There you can break off a little piece that you didn't see extending to the side like a tentacle. So stair is a problem, as I said in my lecture, and obviously ESD, EMD, ESC excavation is a big problem. So there I wouldn't go on the record that says, oh, I'm sure endoscopically this is complete. But for EFTR, I feel much more confident.
I see. Probably we need some standardization of the terminology for the definition of
Yes,
R0 or
absolutely.
endoscopy. Yeah, yeah.
Some consensus
Yes,
statement, yes.
Okay,
Yeah,
thank you.
Uedo Sensei, I totally agree with you. So we need some new criteria for resection of the gist or something. Yes, so we have a lot of discussion and would like to continue, but so time ran out. So thank you very much, all the speakers, Stavros and Noria and Philip. Thank you so much. And the next time, so we would like to meet again physically, face to face. So thank you very much, all.